Your bowels. Today we shall talk about your bowels. Very important organ in your body. If you don't have it, hey, let's talk about things that you can't do. You don't get nutrients, aren't able to defecate. This is why we need our bowels. But sometimes our bowels give us problems. And we'll talk about a lot of the common things that really kind of affect a lot of us. So hang tight and here we go. Here's your learning outcomes. We're going to be talking about some of our favorite ones: constipation, nausea, vomiting, diarrhea, upset stomach. I sound like a Pepto-Bismol commercial. So just to kind of put this stuff back into your brain, if you haven't touched it in a while, your duodenum is where your nutrients are absorbed. You've got peristalsis, that's the fancy word for making your guts go. Okay, the sound effects are free. And of course, your colon's major job is to reabsorb water. Whenever it doesn't reabsorb the water, that's whenever we get diarrhea. Whenever it absorbs too much, that's when we get constipation. So we're kind of having the Goldilocks phenomenon. Not too much, not too little, but just right. First rattle out of the bat is going to be constipation. I will tell you that as I think about constipation with patients, one, I always have to figure out what is their normal pattern of bowel elimination, and I have to convince them that it's okay if we don't go every day. But we don't want you to miss a day. We don't want you to skip too many days, because then that's when everything's really start to get backed up in there. So I always ask my patients about, like, okay, well, how often do you normally go? What does your stools look like? If they can do it on command and I can go look at it and see what it looks like, I can really help myself. I will tell you that as a nurse, the first thing I do after I go to the bathroom is I go plop, plop, and then I want to turn around and look at it. I've decided that automatic flushing toilets are the worst things for us, because even though they keep the bathroom looking fresh and clean, it also means that I don't get to assess my bowel movements as much as I want to. Okay. As I'm looking at my patient, I always want to look at their medication list and kind of see what medicines are on there, because there are certain medications that are going to make them more prone to constipation. I also think about my patients who've got renal failure or congestive heart failure, because those patients are typically on a fluid restriction. If we're not getting the right amount of fluid in there, guys, we're going to get constipated. Also, diseases like hypothyroidism and diabetes. So one of the long-term problems with diabetics is they get nerve damage if they don't keep their sugars under control. It really just stuns their ends of their nerve endings, and they don't work right anymore. So one of the things that our diabetic patients will do is they get a decreased peristalsis in their abdomen, and then their abdomen basically, or their GI system, like, should be going like, squishing back and forth. But with these patients, they don't have that, because their nerve endings in their GI system are just like, I'm so stone cold on sugar, I can't move anymore. And so they don't act right. And so because of that, they don't get the peristalsis, which means that they don't poop. So patients with diabetics, who are diabetics, I always ask them about their GI symptoms. When we talk about constipation, we have to talk about non-pharmacological issues versus things that are pharmacological. I will tell you that in this day and age, it is much easier to get all the fiber that you need if you will just eat the right things. So if we eat more from the periphery of the grocery store, so like, you think about it, when you walk into HEB, the first thing you walk into is the fresh fruits and vegetable. If we'll eat a majority from there, it'll fix a lot of our constipation, because we'll get all the recommended daily fiber that we need. For men, it's 30 to 38 grams. For chicks, it's 25 grams. And of course, we want you to have at least 14 grams of fiber for every 1,000 calories you eat. So that helps to keep things moving. The other thing is that we've got some really cool products out there. This is a Fiber One bar. This is birthday cake. It's a birthday cake bar. Okay, I buy these for my children, not because they have issues pooping. I mean, they don't, because they eat their Fiber One bars, but because they taste yummy. I mean, guys, this is birthday cake. Okay, it's pretty yummy. So if we can get them to trick them into eating the recommended daily fiber, it'll help things keep moving along. Sometimes patients don't like to eat their daily fiber, and the reason they don't like to eat their daily fiber is because it's going to also make them toot. And some ladies just don't like to toot. All right, moving on. So again, one of the first treatments we'll talk about for our constipation is our bulk formers. So when we talk about having bulk forming agents, so many of these guys are just over the counter. We got Metamucil, We got Benefiber, but I'm too cheap to buy Benefiber, and I buy the Equate brand. This, you just take 2 little teaspoons, doop, doop, into your whatever you're drinking, and makes you go. And then, of course, there are, I already showed you the Benefiber, the Fiber One bars, birthday cake. Also have some that taste like chocolate chip cookies and brownies. You gotta be careful with these because they taste really good. And then you'll eat too many of them, and it can make you cramp. Okay. So with these medications, with these fiber bulk formers, these won't actually make you go. They just make it easier for you to. They make you want to go. They gotta give your stool like some bulk to it. Because, if you're trying to pass a small little something something back there, it's a lot harder to do than if it has a little substance to it. So these help to provide substance to the stool. These are great medications for patients who have occasional constipation, or maybe they're just not getting the fiber they need. The only other thing I want to tell you about these, if your patients aren't drinking the right amount of water with these can cause them to make a brick back there, okay? And then nurses, okay, because I've never seen a doctor do it, have to go in there and use the magic finger to get it all out. So again, with these medications, the patient has to drink the right amount of stool, right amount of water. Whew, don't drink stool, drink the right amount of water. Another one of my favorite medications for constipation is a stool softener. So with this one, it helps to prevent the stool from getting hard by pulling water into the stool, so that water and fat into the stool, so that it makes them kind of soft and squishy. Again, this is not going to make you go. It's going to make it easier for you to go when you do need to go. A lot of times in the hospital, we give these prophylactically. Some patients take them prophylactic at home. There's only one instant in which you would stop giving a stool softener, and that is if the patient begins to have diarrhea. If they have diarrhea, they don't need this, okay? So be thinking about that. Be thinking about your patient's bowel patterns and how you best need to take care of them. Oh, this medication's name is Docusate Sodium, okay? And again, Walmart has a generic brand of it. These are always fun to identify. I think they're very pretty pills. They're like orange and kind of clear looking. Yeah, they got like a little liquid in them. Give those to your patients. Poop away, poop away. The next set of top of medications for constipations are your saline and your osmotics. These are the ones that we would typically say you give in the AM for a BM and the PM, or you give them in the PM for a BM and the AM, however your brain works. But with these medications, they will make you go. We typically don't like you to use these every day. They can cause you to have some diarrhea, abdominal cramping, and if you take them in enough quantities, they can actually cause some real big issues. So magnesium hydroxide, also known as milk of magnesia, or MOM, as we used to call it, that medication has magnesium as its base chemical. And so because of that, you can get hypermagnesium if you're taking too much of it. So the manufacturer's recommendations for the packaging is something that should always be followed, okay? I'll tell you the most popular one on the list here that I gave you, and that's going to be good old-fashioned Miralax. Miralax is one of those medications. It's clear, it's odorless, it comes in a nice little white powder. All you do is fill the cap up, put it in their favorite drink, and have them drink it down. The good news is, and it's gritty, sorry, it tends not to be gritty once they get it in there, but it'll make them have a bowel movement, and it's pretty good. It's pretty cheap. The polyethylene glycol, so if you see that word, okay, that's Miralax. All right, but those make you go. The other one that we talk about in this category, again, thank you Walmart for having generic brands, is magnesium citrate. Over-the-counter product. This medication, we use this frequently in the emergency department if someone comes in, they're constipated. It's kind of mean, but you have them drink this Sprite and man, boom, 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 it's gonna make them go. All right, again, we don't really wanna ever get to this section of the constipation plan. We wanna give our patients this step-by-step, like the first thing I want you to do is take your daily fiber, and then we want you to have stool softeners, and then we wanna use these. Honestly, what typically happens with these is that we wind up having to kind of start here and then work our way backwards to get our patient on a daily bowel program. Does that make sense? So sometimes we'll start here because they're so uncomfortable and they really want to poop, and then we'll work backwards from there to get them on some of these other products, because we don't want them taking a laxative or a saline osmotic or any of that every single day, but having a daily stool softener or having daily fiber would be something that we could encourage them to do so they can keep their bowels regular. Okay, there is an herbal medication. It's called a couple of different, well, actually, there's a couple of different ones. These really irritate you and get you going. They're going to make you cramp pretty good. Castor oil. I was at Walmart yesterday. I didn't buy it. There's this ginormous jug, like this big, guys. Like I'm telling you, like 2 gallons of milk size of aloe juice. Take that stuff, man. Okay, and boom, here it comes. So again, very irritating to the bowel. Other medications that we can use, Biscadol is our go-to stimulant medication. It really makes the patient just poop all at once. It's kind of, I call it dookie laxative. It'll make you go. It really irritates. It can cause some issues with abdominal pain, nausea, vomiting, and even fainting. Okay, I know you're probably wondering, wait, fainting? Why? So with fainting, what happens is whenever the bowels have this huge like whoosh, and all of a sudden something that's been sitting really still moves through your bowels really fast, it can actually stimulate your vagus nerve and cause you to faint. Okay, so always watch especially your elderly patients if we're having to use this medication. Remember that stimulants and osmotic and saline laxatives, those are interfering with the body's normal process of producing a stool. If the body doesn't have to do something, it's like every other thing in life. If it doesn't have to get up and go to work every day, it's not going to. So patients can develop dependence on the stimulants and the saline osmotic laxatives, because it takes over the body's natural ability. So just remember, if you see a patient and they're taking Miralax every single day, what we really want to do is we really want to get them to the point to where they're taking it every other day and then every third day, and then maybe eventually get them completely off of it and back over here to a stool softener or to some fiber laxative to increasing the fiber in their diet so that they don't need this every day. Make sense? Okay. The other thing you should know is that laxatives tend to be highly abused, especially by teenagers, which sounds kind of crazy, but that late teenager, mid-20 group, they will abuse this stuff in order to help them lose weight, which also means that they're not getting the nutrients that their body needs in order to grow. So be watching for those patients, watching for that age group. Late teenagers, mid-20s, 30s, they'll use these laxatives and help them to lose weight. It does work, it keeps the weight off, but unfortunately, you're not getting the nutrients at that point. Other ones here, mineral oil is something that we really don't want to use anymore, but it's still sold over the counter. It helps to lubricate the stool. Okay, it's basically an oil that you can put in your bottom, or you can do other things with, and it will help you to go. But the problem is it interferes with vitamin absorption. We do have a couple of medications out there that help patients to go. And they're especially helpful with our patients who maybe have chronic opioid usage due to like cancer treatments or other things. These really make them receptors in the stomach or in the intestines to keep moving so that the stool doesn't sit in one place for very long. It just keeps getting passed along so that they can actually have a stool. On the other end of the world, well, actually it all comes out from the same end, but from the other spectrum, okay? So constipation, hard, chunky stools, diarrhea. Ooh, bad diarrhea. Diarrhea, all of a sudden you're like, ooh, and you're off. So these patients who experience diarrhea, I want you to understand that diarrhea is a natural process by the body that says, there is something going on here. It's a toxin and it don't belong down here in my GI tract. So it tries to scoot it along really, really quickly. There are some medications that can actually propagate you having not diarrhea. Antibiotics, medicines for constipation, those type of medications can actually make you have diarrhea. When we talk about diarrhea, I always think about two different populations of people being very sensitive: pediatrics and the elderly. So we want to tolerate diarrhea to a certain extent, and then there's eventually a time when we have to stop it. With our pediatric and our elderly patients, just because of their anatomy and physiology, they don't have a lot of fluids to lose. So when that little body begins to have explosive diarrhea, if we're not replacing that fluid pretty quickly with an electrolyte stable fluid, then those patients can get really sick really quick and get dehydrated and really change their level of consciousness. I want to point out to you about pseudomembranous colitis as being one of the reasons why we sometimes get diarrhea. So I found this fun little slide here, and this is the fun slide. It's all about Clostridium C. diff. We call it C. diff, Clostridium difficile. So basically what happens is then when a patient takes an antibiotic, when a patient takes an antibiotic, I need you to help you understand, and as we go forward, you'll see why. Antibiotics are kind of dumb. I mean, like, they really are. I mean, like, they're kind of smart, but they're kind of dumb. So when you put an antibiotic in your body, that antibiotic is looking for bad guys, right? Well, we have some bad guys that naturally live in our colons, called E. coli. They're supposed to be there. And so because of that, there's this like very harmonious balance, kumbaya, with all of your bacteria that's in your gut. Well, when antibiotics come along, they're not very smart, and so because of that, they will kill off some of the good guys, which then causes an overgrowth of C. difficile in the intestines, which leads to diarrhea. So this is kind of just a brief snapshot of that, but when I hear about a patient having diarrhea, I always check their med list. I'm like, what medicines are you on? Okay, has anyone else in the house been sick? I always ask those two questions so that whenever I'm processing through, I can think about which way this patient needs to be treated. So with diarrhea treatment, we have a couple of different things. We have a watch and await with the fluid support. So I'll tell my mamas whenever their babies have got diarrhea, I'm like, that's okay. They can have diarrhea. We don't need to stop it right at first, as long as they keep on drinking. Okay, as long as that baby keeps on drinking, we're okay. As long as that elderly person keeps on drinking, we're okay. I recommend Pedialyte for everyone. Now, I'm going to warn you, if you've never tasted Pedialyte, you probably should. It's a little salty, okay? So sometimes we'll tell patients to drink Gatorade. The problem with Gatorade is it has a lot of sugar in it. That Gatorade can be diluted down with about half sugar and half water and half Gatorade, and that makes a big difference. If they stop drinking, at that point, we really need to go to some of our opioid medications. And then, of course, we have some other drugs that we can talk about for our diarrhea of patients who have it for the chronic condition. By and large, you don't really want to stop diarrhea that's caused by poisoning or infection, because that's kind of the body's defense mechanism to get rid of toxins in your body. But again, if that patient's beginning to get really sleepy, they are not recovering well, they're getting dry mucous membranes, they're getting tachycardic, we need to address the diarrhea, okay? Let's talk about our first class. So our first class of medications we're going to talk about is called opioids. So with the opioids, what we see is that it's going to slow down the peristalsis. So if your peristalsis is normally going, in diarrhea, it would go, you get really hyperactive bowel sounds. So with these patients, this medication just kind of slows the system down, allows the body a little more time to pick some of the water out of that before it pushes it on through. These medications can cause a lot of central nervous system depression. We get drowsiness, lightheadedness, nausea, dry mouth, constipation, respiratory depression. You can even get addicted to these medications. Okay, it's an opioid. It's going to make you feel a little goofy and a little loopy. And typically, when we have patients who take either one of these medications that are listed here, they generally wind up sleeping for a little while before getting back up and kind of functioning a little bit more normally. The other issue that we can have is that these medicines can actually stop the peristalsis completely. It's like it was going, you give this pill and it just goes, stop. And then nothing moves through the colon. What that time happens is that the stool will back up and back up and back up, and you get this thing here that I'm showing you on x-ray, which is called a toxic megacolon. And generally we see that whenever patients are infected with C. diff. So other drugs that you're probably very familiar with that are, oh, I forgot to tell you about loperamide. I wanted to tell you about that one, sorry. Loperamide, it's known as Imodium. We buy it over the counter. So loperamide is one of those drugs that like you get it, and then when it goes into the body, it does something different. So it really breaks down into the substance, like literally it breaks down into something called Demerol. And for those of you who have been nurses before, you're like, Demerol, holy camole. Yeah, it breaks down into some really like nasty, oh, actually it's not Demerol, it breaks down to morphine. It breaks down to morphine, sorry. So it breaks down to like an opioid, like an actual opioid inside your body. So again, when people are like, oh, my stomach is hurting, I'm like, have you taken any Imodium? They're like, no. I'm like, you should. Make you feel better. Okay. The other medicine that we got to talk about, some of our miscellaneous drugs here. This is called Pepto-Bismol. That's right, bismuth subsalicylate. Now, I want you to take out the sub part, and I just want you to concentrate on the salicylate part of that drug. That salicylate, that is known as aspirin. That is the chemical structure of aspirin. Okay, so it has a great anti-inflammatory property to it. The bismuth part of that is the one that goes around and starts looking for like bad guys. It's like, you know what, you don't belong here. And it grabs the nasty toxins and takes them with them. With this medication, because it has that aspirin in the back of it, it's got the same chemical structure. We can't give it to children. I know what you're thinking. But Miss Hardy, I was over at Walmart the other day and I was looking through all the medicines because you told me to. And I went over there and they had Pepto-Bismol for kids. Pick it up and read it. It's not bismuth subsalicylate. You know what it is? It is calcium carbonate, which is the exact same substance in a Tums. Okay, so knowing your medications really does help when you start to look at the physical differences of the drug. This medication also will turn your stools black. So for those of you who have taken some Pepto-Bismol recently and then you looked up and you're like, it can make your stools black. One time had a guy come in, he was convinced he had a GI bleed. He'd been taking Pepto-Bismol. He'd convinced. So waited for the man to poop, took the poop, put the poop on the poop card, did a hemoccult on him, came back negative. And we're like, you've been taking Pepto-Bismol that makes your stools dark. Okay, so no children can take this medication because of the risk of Ray's syndrome, and we'll talk more about that when we talk about our NSAIDs. One of the things that we can do for our patients whenever they've had diarrhea is we need to restore the natural flora. So taking a probiotic can and does help. Some of yogurts over the counter have a good amount of bacteria in them and can actually restore the GI tract. There's a couple other ones that come from over the counter. Align is one of them. Reflorastor is one that we use in the hospital. Those can also be given to patients with pseudomembranous colitis in order to help to heal the GI tract and get the good guys back in there. Now we're going to shift focus just a little bit and we're going to talk about irritable bowel syndrome. Irritable bowel syndrome tends to be a diagnosis of exclusion. So the patient comes in and they keep complaining about all these GI symptoms. They roll out all the horrible stuff. And if we can't find anything else to call it, we call it IBS. So with these patients, we have non-pharmacological versus pharmacological treatments, and we always start with our non-pharmacological first. And actually, evidence-based practice says that there's not really a huge difference between the non-pharmacological guys and the pharmacological treatments. Okay, I will tell you from someone who has a little bit of an IBS that relaxation works up until a point, and then I need some drugs. Okay, all right. So again, making sure that these patients can identify their triggers. Are they taking their fiber supplements like they're supposed to be? Benefiber every day has got to be a part. Getting the right amount of fiber every day has got to be a part of their routine. Making sure that they've got their stool softeners when they need them, or are they primarily a diarrhea candidate and they got to make sure that they've got their treatments in their bag in case they need them. So the first way that we treat IBS patients is we give them an anticholinergic or an antispasmodic. So these medications, guys, we've already kind of learned about anticholinergic, and you see here your wonderful list of side effects. Okay, so with these patients, we have to make sure that we don't overdo it with these and make sure that they are getting the appropriate amount of fiber. They're taking a daily stool softener because constipation is a major side effect if they take this medication. I'll tell you, out of these two, dicyclamine is probably the most frequent one that you'll see in this community. Every once in a blue moon, I'll still see some hysamine out there. It also goes by the drug name Levocin, but it just kind of depends on the day of the week. And these medications are all going to slow the GI motility. Sorry, I do that every time. IBS constipation. So sometimes patients with IBS have predominantly diarrhea. Sometimes patients have predominantly constipation. And then there's those fun people who are constipated in the morning and have diarrhea in the afternoon, or vice versa. So with the constipation treatments, we've already kind of gone over that. You know that we need to kind of build up to using the laxatives when you start low, go slow, and build up. Well, if we get to the point to where the patient is, these over-the-counter treatments aren't working and they're really suffering from constipation, then we may need to add a couple of different medications or try some different things. Linaclotide, also known as Linzess, helps to kind of draw the water into the intestines and works really well to help to relieve constipation. Amizeta or luperazone, it increases the movement of the intestines, but again, because we're increasing the movement, they may have a little more abdominal pain, distension, they may fart more, and then they may develop diarrhea. And then the weird one here is that they may have a headache. Okay, so I typically don't see these very often in the community. I do see them every once in a while. If usually these type of medications come out of they've been to a GI specialist and they've recommended them. For the patients who have predominantly IBS with diarrhea, so we already kind of covered that, keeping those patients with the OTC treatments, loperamide, if it gets really bad, Lamodal, those sort of things that come from a physician. We do have some medications. These are biological response modifiers that help these patients to prevent the diarrhea. You can see the signs and symptoms there. Again, if they're on these type of medications, they're typically coming out of a GI specialty office who has prescribed these medications for them. So let's kind of shift gears a little bit. So let's say that a patient comes in complaining about diarrhea, constipation, abdominal pain, and we go in, and one of the first things that they'll do is they'll try some therapies and some treatments. If those doesn't work, then typically they want to stick a camera in their bottom and do a GI series to see what's going on. At that point, we can get a diagnosis of either Crohn's disease or ulcerative colitis. Basically, these two disease processes have kind of the same general symptoms. Okay, if I was going to distinguish ulcerative colitis from Crohn's disease, I would tell you that ulcerative colitis more often than not will have some episodes of some bloody diarrhea, okay, and it looks all bloody. Versus a Crohn's disease, whenever we go in for those patients, they don't have the bloody diarrhea, and their scan or their examination with the camera in their bottom looks a lot different. Here's a picture of what it looks like in a patient with ulcerative colitis versus Crohn's disease. In the patients with Crohn's disease, they have these things called skipped lesions. So they put the camera up their bottom and they start looking, and they may see a lesion, and they may go a little bit further and see a lesion, and go a little bit further and see a lesion, a little bit further, nothing, and then see another lesion. Versus someone who has ulcerative colitis, those lesions are continuous through the large intestine. Okay, so that's kind of the difference. The good news is it really doesn't change the treatment. We have a difference in the disease process, but the treatment is about the same. So our ultimate treatment goals here are listed as we want to keep this patient happy, healthy, out of the hospital, and feeling great. We don't want this disease to get any worse. We don't want it, and then we know it's never going to go away. We just kind of want to keep it in remission. And then we want these patients to have a game plan. This is step 1, this is step 2, this is step 3, this is how you're going to treat your symptoms. So step 1 are these fun drugs, aminosalicylic acid. And again, you see that salicylic acid part start to show up in there. You just kind of start thinking about, this drug may be similar to aspirin in a way that it has anti-inflammatory properties. And you'd be absolutely right. So with this patient, if they have any allergies to sulfa or aspirin, they can't take these medications because they can cause them to have an allergic reaction. They can develop something called crystalluria, which basically what happens is in the urine, so the body takes the drug out of the system and puts it down into the bladder. If that bladder doesn't have enough water in it in order to dilute the medication, that medication will begin to get hardened and crystallize and then hang out in the bladder. I don't know if you've ever peed crystals or not, but it's probably not any fun. So be thinking about these patients need to make sure that they're drinking an appropriate amount of water. One of the things that can happen with these types of medication is that it can be, you get too much of a good thing Okay, we're wanting this medication to kind of help to suppress the immune system a little bit, especially in the bowel. We're wanting it to just kind of control the inflammation. Well, sometimes when we control the inflammation, our bodies are like, oh, fine, fine. You don't want my inflammatory responses anywhere? That's perfectly fine. I'm going to weaken I'm not going to give you anything. I'm not going to produce any white blood cells. I'm going to get bone marrow suppression, and let's just see how you like that. Okay, so sometimes this medicine can be a little sassy pants, and it can weaken the bone marrow. It'll suppress the bone marrow to the point to where you're not getting any white blood cells. So we have to watch these patients. We have to tell them that sometimes their immune system is going to be kind of dampened. So like if all of a sudden a bad cod comes out and they go, whoa, they're not going to go, whoa, they're going to go, whoa, okay? Their immune system is suppressed. So they may be more at risk for infections. So teaching them to wash their hands, stay away from clotted places, don't handle small puppies or any small animal. When you get done handling any kind of animal, you need to go wash your hands, using lots of hand sanitizer, making sure they're keeping their yearly appointments, making sure they're keeping up with all those fun health screenings, their pap smears, their testicular exams, their breast exams, making sure they're going in for a yearly eye exam. Whenever this person gets sick, this is someone who needs to present to their primary care's office whenever they feel bad, not whenever they're running 103 fever. The step two. So let's say we've done step one and step two, and now the patient isn't getting any better. So now we may need to add an additional medication. Again, these medications are all steroids, okay? Steroids suppress the immune system even further. So if we did step one, and now we're doing step two, because you can do these concurrently, we may have a trouble with this patient's immune system. I'm hoping that you're recognizing that you've seen budesonide before. We saw budesonide when we talk about patients who have allergic reactions or who have asthma. It's one of our favorite steroids to give our patients orally. Oops, sorry. So one of the things that we do with this medication is that the budesonide has been specially chemically formulated to have like this special armor around it, so that whenever it goes into the mouth and it's traveling all down and it gets into the stomach doesn't destroy it. In fact, it can get all the way through the small intestine and then pop out into the large intestine, and that is where it magically opens and has a topical anti-inflammatory effect. So budesonide would be one of those medications that would be really great because we're not getting systemic effects, we're just getting a localized chemical effect from the drug. Way to go, chemist. Step three would be our immunosuppressant drugs. So we've gone from one, we did two, and now we're at step three. So this is the patient who has to come in and have regular infusions of this medication. We do have some of these are oral, some of these are infusibles, but the problem is that it can take up to 3 months for this medicine to work. So it's a really long time before the patient begins to see any therapeutic benefit. Step four, this is our biological agents. Again, this requires a special authorization from the insurance company. It requires a special administration policy. You're going to have to go to the cancer clinic to get this stuff done. These medications are great, but again, it requires, this is kind of like our last ditch, last step effort in helping someone to get their irritable bowel disease under control. This is kind of a slide. I want to point this out to you because typically whenever providers are prescribing these medications, they come because of a recommendation from a learned authority. So like a GI specialist, okay? So this is kind of like the flow sheet of for a provider on how they would prescribe these medications. Step one, step two, step three, step four. And you can see we followed kind of the same pathway as we were talking about our medications earlier. They just have a little more fancier names for them. So just want to point this out, that whenever you see someone who's on this step therapy, that someone who's a learned authority, who is more smarter than your family practice doctor, is making these decisions based upon evidence that they have from practice and from research studies and so forth and so on. Okay, so this is called a clinical guideline. Ooh, nausea and vomiting. No thanks, I would rather die. I do not like to be nauseated at all, and I'm pretty sure that I am not one. I am more than There's more than one of me out there that does not like to be nauseated and vomiting. So just a brief reminder that there's two different things that kind of stimulate your vomiting. One, you have a vomiting center in your brain. Thank you. It's located in your medulla. You also have a chemoreceptor zone, which is in your cerebral cortex. Very interesting. Your creator knew that you needed to have a way to puke. So the chemoreceptor zone is actually located outside of your blood-brain barrier, so it can continually detect whether or not you have a toxic substance in your GI tract and whether or not you need to get rid of it. Which leads me to my next statement, which nausea is really a symptom of something else. No one should just walk around and be nauseated all the time. There should be a reason you're nauseated, okay? Some drugs do have emetogenic potential, meaning that they have more of a propensity to make you want to puke than others. When I think about chemotherapy drugs, those typically have a high emetogenic potential. And as you have a patient who's taking chemotherapy, they always want to know, am I going to be sick? And usually whenever we talk about being sick, it's how much am I going to puke with this medication? Vomiting. Two populations of people, just like with diarrhea, my elderly and my peds, I am looking for them all the time with vomiting. They can tolerate very little because it's going to shift their pH of their body. And if they get enough fluid volume deficit, they're going to have a complete and total vascular collapse. So we watch for the dry mouth, the sticky membranes, a reduced urine output. Again, your urine should be mostly clear. If you're watching someone pee and it's not mostly clear, they need more fluid. So we have a couple of different antiemetics that are used to treat vomiting. We have a couple different classes, and we'll kind of work through each one of these classes so that you can kind of see what's going on. I will tell you that by my basic non-pharmacological interventions for someone who is vomiting is I'm like, once you throw up, you're nothing by mouth for 30 minutes. Then you can have ice chips for 30 minutes. Then you can have small sips. And when I say small sips, I will hand them a medicine cup. And I say, you can have one of these every 5 minutes. And at any point in time when they puke, we go back to step one. Okay? Absolutely no dairy products during this time, no milk, no milkshakes, no ice cream. Those sort of things tend to irritate the stomach. I will tell my patients that if they've got diarrhea and vomiting, we gotta get the vomiting under control and then we'll worry about the diarrhea second, okay? So let's walk through each one of these medications and go from there. So the first antiemetic, I hope that you have all experienced this. The most popular one here on the list is going to be Zofran, ondansetron. Great medication. We tended, when it first came out, we only used it like before, like chemo, radiation, surgical procedures. Now I feel like that this has really become like the mainstay of our treatment for any type of nausea. The great news is that we don't have to worry about giving it always IV. We also have these things called oral dissolving tablets. And as you know, when you put an oral dissolving tablet on the mouth, we bypass first pass effect. It's in the mouth. It dissolves right here. It never had to go through the GI system in order to get to its target action. So great medication to use with patients who are nauseated, but they're still puking. If I tell them, I'm like, look, you can take this medication right now, and if you puke 30 seconds later, you got the medicine. All right, so great medication. Does cause a headache, can cause constipation or diarrhea, and of course, everything causes dizziness, I feel like. Our next set of medications is our antihistamines and anticholinergics. So at this point, I hope you have memorized what anticholinergic side effects are. Drowsiness, dry mouth, sedation, tremors, seizures, hallucination. Fun thing about our antihistamines, we can have those paradoxical reactions. Remember what those are? It's whenever a person is supposed to act one way, but they get something else. So I always think about Benadryl. Sometimes when you give kids Benadryl, they're supposed to be sleepy. Instead, it makes them cuckoo for Cocoa Puffs and they get all wound up. And they can also cause hypotension. When we're talking about taking these medications for motion sickness, we want to take them 20 to 30 minutes before we actually travel. So typically medications on here that we would use for travel, we would use diphenhydramate, which is the Dramamine, makes you very sleepy. Meclizine, which is also known as Dramamine. You got to read the chemical on the box. It'll say non-drowsy sedation for motion sickness. And then there's a little thing called scopolamine. Scopolamine is a little bitty round disc that has medication in it that is transdermally released. Typically, before the person travels, they'll put it behind their ear, and then it stays there until the next dose is needed. So, but again, for motion sickness, we need to take them 20 to 30 minutes before, 20 to 60 minutes before we travel in order to make sure that we don't puke. I have a church camp coming up in a few weeks, and I have a couple of kids that have horrible motion sickness. And so, like, their mamas are all, I'm like, no. These 4 kids all get meclizine before we leave. And absolutely, positively, none of you are sitting anywhere but in the front of the bus with your bonnet bag with the cool air blowing on their face and peppermint oil on to help them prevent them from puking. Because if I set those 4 kids off and they start puking, the rest of the bus is going to puke. And then we have a miserable start to camp. Other drugs that we can take are phenothiazine and like drugs. I starred some couple of them here because these are the medications that you're going to see most frequently in our community. These medications, again, have very similar side effects: eyes, blurred vision, dry mouth, constipation, drowsiness. The weird one here is photosensitivity. I love it whenever your book, like all CAS, is like, oh yeah, it can cause neuroleptic malignant syndrome, like just real casually, like just blah, and then like doesn't explain what it is. Okay, drives me insane. Okay, so what neuroleptic malignant syndrome is, it's a life-threatening reaction to an antipsychotic drugs, but it's not just antipsychotics, it's also these that will cause fever, altered mental status, muscle rigidity, and like autonomic dysfunction. So like whatever it's supposed to be doing will do completely the opposite. So these medications can be really, really scary to give. So a couple things. So with metoclopramide, I always give that medication very slow IV push when I'm giving it IV. I tell the patient that one of the things that happens with them is that when you give this medication, all of a sudden they have the need to move. Like they're not uncomfortable. It's just like they have this propensity that they've just got to move. Like their legs will start moving. They'll have to start stretching more. They might start yawning. Oh, sorry. That turned into a whirlwind. So these medications can all cause those kind of just weird, like I can't sit still kind of movements. Reglan metoclopramide tends to be the worst one about this. Promethazine and phenergan are very, very highly sedating. We used to give promethazine all the time to small children. However, we came out with a black box warning a few years ago because this medication began to cause children to spontaneously stop breathing. So we don't give phenergan anymore. The other good news is that both compazine and phenergan both have a rectal version. So if you have someone who's just puking and puking and puking and you're in the middle of nowhere and can't start an IV, can't give it to them IM, you can go rectal with the medication. These are corticosteroids. Now, I will tell you, in my lifetime as a nurse, I feel like I have seen corticosteroids given very infrequently to patients with nausea and vomiting. Typically, we're able to control them with all the other classes that we have. The most frequent patient that I see that needs corticosteroids are those patients who are treated with chemo medications, or if they're having a post-surgical nausea and vomiting type of reaction. These medications do carry their own set of side effects, their own sort of risk factors, especially if we're doing them long term. Please understand that like if we're giving them like 1 dose or 2 doses, you're not going to see these adverse reactions. But if this patient was to need to be on this medication for months, then we would start to see some of these adverse reactions begin to occur. It doesn't happen with just a first dose. It's more of a accumulation of doses. So just to be thinking about that you can use corticosteroids in the treatment of nausea and vomiting. Again, one of the very many uses for corticosteroids. We do have a new kid on the block. This new kid on the block is the neurokinin receptor antagonist. They found that these neurokinins helped The neurokinins in your brain are also turning and stimulating your vomiting center and your chemoreceptor centers. So it's a little bit further down on the physiological pathway. They do have some of the same side effects as the others that we recognize today. Kind of weird, like we have one that it does cause some blood abnormalities, and it actually causes you to develop pneumonia. So really weird. All right, guys. That is everything for your all about bowel disorders. If you guys have any questions, please don't hesitate to ask.